Brooklyn Independent Television.
Coming up on Healthbeat Brooklyn.
Tell them the difference between a healthcare proxy and a living will.
The complex issues that arise when you treat those nearing the end.
Advanced directives are not written in stone.
From New York Methodist, two geriatricians and a nurse discuss their approach.
We had to treat the family, not just the patient.
And an ER doctor decided he'd seen enough death and injury resulting from teen violence.
Your network contributes to your net worth.
He created a program to help kids recognize the risk factors and give them a range of other choices in life.
For our check-in today, you're going to write down what your goal in life is.
We say youth empowerment first. Yes, we know violence is an issue, but what other opportunities will we provide for our young people?
All this and more on Healthbeat Brooklyn.
Welcome to Healthbeat Brooklyn on Brooklyn Independent Television. I'm Dr. Monica Sweeney. All of us eventually face end-of-life medical issues for our parents, for a spouse or sibling, for ourselves. Now that the baby boomer generation has started to hit 65, it's going to happen to more people in a relatively short span of time than ever before in our history. At some level, we all know this day may come. But too many people fail to make plans for it. Plans that might ease the stress simply by taking the time to think about how we want things handled. How much medical intervention do we want? Who should be making those decisions? And then there's the actual expense. Americans typically spend more on health care in their last 30 days than in the rest of their lives combined. Here to talk about how they help patients and their loved ones deal with these issues at New York Methodist Hospital, and to give us some examples of different patients they've encountered are Dr. Louis Muddanayake, Chief of Geriatric and Palliative Medicine, Dr. Donna Gore, Fellow in Geriatric Medicine, and Joanne Lanyezi, a registered nurse and co-chair of the hospital's Bioethics Committee. Thank you all for being here, and thank you for being back. So, what is advanced directives, end-of-life care?
Advanced directives really came about as a result of the Patient Self-Determination Act. And they really represented, in theory at any rate, what patients would want in terms of their medical care when they did not have capacity to make decisions.
It represented what patients would want.
Would have wanted.
Would have wanted when they don't have capacity. Joanne, what are advanced directives?
Advanced directives can come in many forms. Normally, a patient, when they do have capacity, could make what we call a healthcare proxy. And that's when they designate an agent, someone they trust, be a family or friend or someone they're close to carry out their wishes when they lack capacity to do so.
Now, when you say lack capacity, just for our audience to be sure we're all talking about the same thing, would you talk about capacity? Any one of you.
Capacity, can be looked at as different depending on what kind of capacity we're talking about. So, for example,
let's talk about mental capacity right now, cognitive functions.
You can have an elderly demented person who has sufficient capacity to say, look, I would like a glass of water, or I would like certain basic needs being met. But the kind of capacity we talk here is actually much more complicated in that it involves understanding treatment outcomes.
Well, that's very important, the treatment outcomes, because, I could say, and I'm sure you've had patients say, do everything, I want everything done possible. So is that having the capacity when someone just says do everything?
Well,
is that enough?
I think the key step there is to ask the person, what do you mean by everything?
Okay.
Because that sets the stage for that person to develop a strong mutual bond with you and open up themselves and give you a better understanding.
Well, you talk about it in terms of what it would be in a primary care setting where you've developed, or a chronic illness that you've developed a relationship with your clinician. But many times when people are in need of hospitalization, they may come in the middle of the night when the primary care may be away for the weekend and whomever else. I know you've seen cases of this as a young fellow in the hospital a lot.
Absolutely, and one of the cases I want to bring up was the patient who was 96-year-old African-American woman who was pretty much functional and was independent in her daily activities of daily living, where she would go grocery shopping, she would go to adult daycare center, and she used to live independently with her family close by. Unfortunately, one night she developed chest pains and was brought into the hospital with that particular complaint. And it turned out that she had a massive heart attack and had to be resuscitated, placed on full life support. So at that point in time, as in New York Methodist Hospital, Interdisciplinary Advanced Care Planning team, we met with family to establish what would be her goals of care and provide options and provide guidance to the family in terms of what to do in that particular situation.
Did she have advanced directives?
She did not, Dr. Sweeney, and it happened to be that I came upon the case right before Anna and Doctor were involved, and it was really at that point I wanted to establish the family dynamic. Who was involved in her life? What was the relationship? Because the family dynamic is also very important when we make these decisions. And at that point, we really sat down because we didn't know what her quality of life prior to her coming into the hospital. We meet her now in a status of being supported on ventilation. So at that point, we all meet together as a team and try to focus on what the patient would want if she could speak to us at that point.
Once you got to sit down with the family, had she talked about her wishes with any of the family members?
I think Joanne just hit on a key issue, and that issue is the culture of the patient. Mm-hmm. Her own culture was one of this feisty.
I like a feisty 96-year-old. It's a very good place to be.
Who would insist on specific things in the grocery store that she would go to. So this was clearly a woman who respected her own autonomy and expected her children to do this. That was the impression that we got.
I agree with you.
And she also had some discussions with the family about what she may or may not have wanted.
You know, I'm glad you brought in family early on, because I had, as a practicing internist, many times when one family member would want one thing and one family member would want another, and legally they both had the same standing. So what do you do in a case where one child says, I want you to keep my mother on this life support because life was precious to her, and the other child says, Mom would not want to be lingering here, not being able to look forward to living her independent quality of life again? What do you do?
I think your question has the actual answer in it. And the focus should be not what you want, but what would she have or he have wanted. Mm-hmm. And that's something, you know, we at New York Methodist Hospital Interdisciplinary team for advanced care planning, we try to arrive at family consensus.
Yes, absolutely.
Because it's the decision-making process very often.
You talk about family consensus, but suppose the family doesn't come to consensus, but the person she was closest to says, this is what my mom said she would want. Then?
I think obviously we have to respect that, but that doesn't preclude the fact that we make every effort to get a family
and as
consensus.
We said, the focus is on the patient's wishes.
You know, I'm going to go and ask you about a couple of other cases, because I know you've had many. I mean, I could just pull back and bring out many also, but I want to talk about one thing very important here, because you talk about an interdisciplinary team. And I want you to talk about the interdisciplinary team and briefly what your function is, so that there are people out there not thinking they're death panels. Because you know there have been some people running around with the Affordable Care Act telling this major lie that they're death panels. This interdisciplinary team, please describe it and what your function is.
I think the best way is to give an example, and it's one of our examples where there was expertise that was required outside of the expertise of the medical and nursing team to alleviate the existential suffering that this woman was going through. So I'd like to, Anna, if you want to just talk about
This was a young 46-year-old woman who was battling breast cancer for the last 5 years. She was living independently, had 2 children, but unfortunately her husband passed away, so she was the sole provider for the family. And when she came to the hospital, she basically was admitted because she was paralyzed from waist down because her cancer has spread and none of the treatments were working. So at that time, she was faced with a lot of decisions in terms of what should she do next, in terms of would she continue with aggressive measures as much as possible, or would she step down and say, well, let's treat my symptoms instead of the disease, but let's treat the symptoms. And that conversations took on many levels, and many times because her hospitalizations was very severe, she had multiple complications. And it took not just one effort, it took many efforts on behalf of medical team, the nursing team, the social workers, the pastoral care team to guide and discuss it with the patient. And ultimately, it was her decision to decide that, no, this was enough, and she decided that she would rather treat symptoms instead of the disease.
Palliative care.
Yeah, I think there are 2 key take-home messages. The first take-home message is advanced directives are not written in stone. They can be changed during the disease.
Fluid.
During the disease trajectory. And the second piece, which was addressed by the interdisciplinary team, what use was I as a physician if my providing morphine did not get rid of this woman's pain? The real pain that she had was a suffering where she was thinking about her young teenage children, what was going to happen to them. And the moment the pastoral care stepped in and they were able to come to some sort of conclusion, her advanced care planning changed completely.
So the multidisciplinary team involved all of those people with the patient at the center, is what I'm hearing. And then based on putting everything out there, then a decision was made. She made a decision about what to do.
It was more than treating her disease process at that time.
Right.
We had to look at the whole family.
The picture.
We had to treat the family, not just the patient, to get her to some sense of acceptance for her disease process.
And what was going to happen with her teenage children.
That was a big concern to her.
And that was causing her so much pain. Right. And when you're in pain, decision making is a very difficult thing.
Mm-hmm.
You mentioned healthcare proxy.
Mm-hmm.
Would you tell them the difference between a healthcare proxy and a living will? Because people always ask that question.
Okay, as I said, a healthcare proxy done by the patient to designate an agent to be the medical decision maker when one lacks capacity to make those decisions for themselves. A living will is also specific treatments or lack of treatments that you may or may not want to have at the cause of an end of life, a loss of consciousness, a terminal disease. And at that point, that living will is really used as a guide for your agent, if there is a proxy along with that, to follow out your wishes.
I don't want intravenous.
I do not want artificial nutrition. I do not want mechanical ventilation. I do not want to be resuscitated. I do not want any form of antibiotics, if necessary. That is a guide for our agents to carry out.
You didn't mention a durable power of attorney. Would you just talk briefly about durable power of attorney?
That's part of the advanced care planning also, and that's a situation I come into a lot with power of attorney or lack of. And that's very important when you have loved ones in a hospital that cannot do their financial business. And without that power of attorney, they're really crippled to carry on any of their monetary concerns. So having a power of attorney to designate someone to take care of that is really part of this whole planning process.
Would you explain the durable part?
The durable is, at that point, that person is responsible to do whatever is indicated. There's certain on that form, it could be from just going to deposit a check to really taking care of estates and taxes and information, depending on what that patient chooses at that point. And only a patient with capacity can, designate someone to be a power of attorney. A lot of times I have people come and want to, please sign this power of attorney, but my patient can't tell me they want Dr. Gorlick to be that representative. So it has to be notarized.
They have to have capacity, be conscious, cognitive,
of who
not
they're
on
designating, absolutely.
And, right. And Joanne, where do people find the forms that you just mentioned?
Healthcare proxies can be obtained online. Most hospitals also have them available to all our patients. Power of attorney you can get at your bank, at your local bank, a stationery store, but really everything is available online.
I think this is a key point also, the fact that advanced directives should really be what we call advanced care planning. Advanced care planning means that you keep revisiting. And in the case of this young white lady with the advanced breast cancer, we had to keep revisiting and revisiting. As geriatricians, we feel that advanced care planning should almost be like a vital sign, because that respects patients' right to change as well as a change perhaps in the disease trajectory.
Mm-hmm. Culture plays a major role in this. So I know the hospital, Methodist Hospital, has a great diversity in their patient cultures. So tell me something about how culture has played a role in some of the decisions you all have faced with helping patients do this.
I think we are in Brooklyn. Brooklyn is a very diverse community, and we have to understand that a lot of ethics is based on Western ethics. Mm-hmm. So, for example, I had a 90-year-old Chinese lady who was faced with multiple comorbidities and a terminal illness, an elderly geriatric patient of mine. And it was interesting to see that she deferred decision-making to not just her two sons, but to the extended family. But then there is also the huge danger of cultural stereotyping. People, oh, this lady is East Asian, therefore the family makes a decision. It's not true.
So even within the larger culture, Asian, if we will this time, we can't think that because this woman did it that way, that everybody's going to do it that way. We have to individualize it for the situation, which is what I'm sure you all do all the time.
We try not to cultural stereotype. We try to go into the individual case. And very often, people who are not physicians, be they, practicing rabbis or whatever, they can give us real insight into what these people really wanted. I mean, another example was an elderly Muslim man, 85 years old, who came into the hospital on a weekend. There were 19 people in the hospital room. And I looked at this man, and he looked at me, and he said to me, they make the decision. Ultimately, I was caught between a rock and a hard place because they were squabbling amongst themselves, the 19 individuals.
One of the take-home lessons is for everyone, young mothers with young families with children. What happens if something happens to the mom and the dad? Have they planned? Elderly patients. Everyone should have advanced care planning. Instead of directives, I like your word, advanced care planning. And more, we're all going to need to do that. And thank you all for enlightening us on what it is we need to do. Thank all of you for being here.
Thank you.
Thank you.
Thank you very much.
Violence can be very seductive, and not just in movies or video games or on television. For certain young people in particular, violence brings with it a false sense of power, and often fatally for someone. The mistaken idea that a gun or a knife is a fast and effective tool for fixing a problem. To be sure, Brooklyn has its share of teenagers who have grown up thinking this way, often due to factors far beyond their control. Too many of them have ended up in the emergency room at Kings County Medical Center. That's where a young ER doctor got the idea to create a program that encourages these young people to look hard at the reasons they might be tempted to use weapons instead of words.
You guys have report cards today, right? All right.
I don't think they even seen
No sad faces. All right. Dude, this is way better than last year. I guess. Dude!
That's what I'm talking about.
Good, congratulations!
Wow. I see some 90s. 90s?
And it's not even in the gym.
For real.
KAVI stands for Kings Against Violence Initiative. We are a hospital and school-based program focusing on youth empowerment, but also helping focus on violence intervention and prevention.
What's going on? You passed everything.
Yeah, but I could have done better.
You're damn right. There you go.
So, I grew up in Brooklyn, and based on a lot of things I saw growing up, especially related to violence, we started seeing the same things happen as I got older. The same things happening when I moved back to New York after finishing residency. And what we see in the emergency department is a lot of young people who've been injured, that have been subject to violence, but a lot of the stuff was avoidable. And so we started looking at what can we actually do as physicians, what can we do as health practitioners, what can we do as public health individuals to help decrease some of the injuries that we're seeing. This patient came in, this is the second time coming in for a gunshot wound. But you see he's got surrounding pulmonary contusion. Our focus is youth empowerment, and we say youth empowerment first. Yes, we know violence is an issue, but what else are they going to do? What other opportunities are we going to provide for our young people? So looking at what we're doing in terms of providing different types of social support for the program, helping provide different access to other opportunities that are going to empower individuals. That's a way that we can help decrease the incidence of violence that we see coming into our hospital and also within our communities.
You want to own this business. You want to make the money. You have the idea. What does it take? And what
we're in the school 4 to 5 days a week. When we're doing our sessions with, in the school, it's a huge group dynamic. And we have a session for the guys, we have a session for the girls. Also, the topics that we cover are a little bit different for the guys as well as the girls.
So you guys see these pictures up on the wall. What do you guys think we're going to be talking about today?
About respect.
Okay.
Portray themselves.
What happened?
How girls portray themselves.
Okay. We're just pretty much trying to get them to be better individuals, and we also want to give them the tools for them to be able to, sustain themselves throughout life. How did these pictures make you feel, Christy?
Those pictures make me feel like a lot of girls make them portray themselves that way, and when boys see that, they kind of think that all girls are that way, deep down inside, so it gives them a bad image.
Okay. And also they think of one thing.
Yes, that's exactly.
She looks like she's doing some type of sports or she's modeling for something. And then she looks like she's stripping for her boyfriend. It's different, and I don't think you should take a picture like that.
You don't think?
Okay.
I think that's unfair how people just judge someone because of their past legacy. Maybe she might be doing this last year, and then next year, she's like, you know what I did in the past was bad, but now you guys are looking at this picture, I'm not gonna accept her.
You said earlier, we shouldn't judge people, right? We shouldn't make decisions about people. And then I think in a perfect world, that would be nice, right? But it goes back to exactly what Z is zeroing in. If you do a certain thing, whether you are not that, this young lady's not a smut, but because she does smutty type norm things, she's perceived as a certain type of person, and I think that's what we're trying to drive home today.
Many of the students that have come into the program may have a history of frequent fighting. Some of them have been doing poorly in school. Some of them have had known gang involvement. Some are just knuckleheads and need additional mentorship, but they're all very bright. But just like myself, just like a lot of my friends, we need additional support. You can't look at the school as the primary source of providing support for young people. You can't look at your parents as the primary support for young people and helping provide their general growth and development. So it has to be a multifactorial, multidisciplinary approach.
So is this positive or negative?
Negative.
Negative? Is that one positive or negative?
Positive.
And the next one?
Positive.
Their mentality, just their whole being has just evolved. Most of them have been in the program for a year, and if you came last year, completely different girls. They're starting to think about how their actions kind of affect them, either positively or negatively.
If you know you want a good future, you want to go to college, you want to do stuff, why are you posting pictures and stuff like that up on the internet?
Okay.
You should think of your future before you do something.
Like that. I have been in the KAVI program for a year now. I was able to mature from the program. I was able to actually focus on my goals and not give up.
because there were some times that I wanted to give up on like my goal of going to Harvard, and I had people in the KAVI program to encourage me and tell me not to give up. So they helped me with my schoolwork, like with the KAVI after school program tutoring and other stuff.
That network is going to actually contribute to your net worth. Your network contributes to your net worth. Y'all remember that? Write that down.
Seeing us, how we look like them, we come from the same places they come from. We all are here from Brooklyn or from the inner city. We've all have had our own challenges with our youth and our adulthood, but you know what, we all have persevered. So it's for them to really find their greatness, tap into it. You know what, knowing that the sooner they become committed to their careers, the sooner they'll be successful.
Those are people, so you could start your business just even on your block.
In 2 to 3 years, we hope to be able to expand our school program. Our school program is currently in 3 different high schools in Brooklyn. On the Wingate High School campus, we hope to expand to other schools that are considered high risk for having violence take place in the school and outside of the school, as well as in the surrounding communities. We also hope to expand the scope of our program, and especially as it relates to social service and biopsychosocial and behavioral health services that we can provide to the patients and their families.
You know, look at you guys. Proud of you guys.
That's all for this month. To watch either of these segments again and to see all of our past healthcare stories, go to brickartsmedia.org/BIT and then click on Healthbeat Brooklyn. And you can follow us on Facebook or Twitter on BK Independent TV. I'm Dr. Monica Sweeney. Thanks for watching and stay healthy.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.